Welcome to AETCM. 87-year-old male, known case of CAD, triple vessel disease, status post PTCA stent to the LAD, type 2 diabetes mellitus, CKD, diabetic nephropathy, and history of diabetic retinopathy is present, and systemic hypertension and COPD.
Okay.
He initially presented to the OPD, podiatric OPD, with complaint of left foot swelling since 1 week, fever since 2 days, and where his initial blood pressure was found to be 160, pulse rate was found to be 110. So, and also they suspected a history of fever, foot infection, they suspected sepsis, and they planned for an admission on emergency basis, and he was shifted to the ER that day. On arrival examination, patient was drowsy but arousable. Respiratory system, bilateral air entry present, normal vesicular breath sound. Upper abdomen soft and non-tender. CNS E4, V4, M6. And on taking the vitals, pulse was irregular, and BP was 80/60, and saturation was 96% on room air. At that time, initially ECG and ABG was taken. ECG was showing absent P waves and irregular RR interval, AF and a rate of 140. So AF with fast ventricular rate was there. And initial VBG was showing a pH of 7.31, PCO2 of 29, PO2 of 80, and lactate of 2.0, and bicarb of 16, and glucose of 600.
How do you classify narrow complex tachycardia?
Narrow complex tachycardia can be classified either regular or irregular.
Okay.
In irregular, AF, atrial fibrillation, and multifocal atrial tachycardia.
Okay.
In regular, it is AVRT and AVNRT.
Okay. So, whatever may be the reason, what is your aim in emergency room? The reason can be varying, like you are told AVRT, AVNRT, atrial fibrillation, multifocal atrial tachycardia. What is the aim of the treatment?
Hemodynamic
Stable or unstable. Unstable means your treatment is entirely different. Stable means what is the treatment? Whatever it is, whether it is stable or unstable, what is the aim of the treatment? Rate control. Rate control is the most important management in emergency room, not the rhythm control. Rhythm control may not be achievable in emergency room, but rate control is very important. Okay.
And initial point of care CRP was more than 250. Okay. WBC count was 15,000, and hemoglobin was 10. And initially, so the patient is in initial provisional diagnosis based on the history examination is patient is in sepsis with septic shock.
Okay.
And diabetic ketoacidosis. Okay. Suspected diabetic ketoacidosis. Okay. Because acidosis is there in the ABG and sugars are elevated. Okay. And patient is in AF level? With fast and
lactate
2, sir. 2. Patient is creatinine in the VBG it is 2.4, sir.
Okay. What are the reasons for acidosis in a diabetic patient who is unconscious?
Diabetic ketoacidosis.
And lactic acidosis. Then renal failure. Renal failure is one of the important causes.
Yes.
Okay.
And initial lab showed serum ketone 3+ and urine ketone 2+.
Okay.
So first, as per the surviving sepsis guidelines, we've started the patient on empirical antibiotic.
What is the first line treatment here?
Hydration.
So to give hydration, you need to know whether the patient is dehydrated or not.
Yes.
How do you know that this patient is having cardiac failure, this patient is having DKA? So there is a high chance of dehydration, but how do you confirm it?
If any basal crepitations are there.
Clinically, how will you confirm dehydration?
Pedal edema.
So capillary refill time 1. Then IVC collapsibility, tachycardia, tachypnea. All these features you have to see. Then only we can correct it. Sometimes fluid deficiency will be there, but when you start fluid, patient may go to cardiac failure. Okay, so you have to be very careful this type of patients. Clinical monitoring also important. Okay. So first line is always fluid. How do you manage fluid therapy in this patient?
In this patient, as the patient is in
Have you done
diabetic ketoacidosis,
BNP in this patient?
BNP at
Is
that point of time,
it is
no,
not done.
not
Okay.
done. And in view of uh, DKA, ideally the fluid requirement would be around 6 liters.
Okay.
So for the first 1 hour, as the patient is also in septic shock, we've given a fluid bolus of 1 liter.
Okay.
And
What is
then
the advisable fluid bolus in adult in septic shock?
30 ml per kg.
30
30
ml
ml
per.
per kg.
Which fluid you give?
Isotonic. Isotonic fluid.
What is the ideal fluid?
ringer lac.
Normal saline or ringer lactate. Normal saline is the choice because that is cheaper than ringer lactate. Ringer lactate, any contraindication?
AK,
Like if the potassium is high, it has to be restricted. Otherwise, ringer lactate is equally effective or better than normal
normal
saline.
saline.
Only thing is normal saline is cheaper and available everywhere. What is the adverse effect of normal saline if you give massive boluses?
Worsen
Hyperkalemic
hyperchloremic
metabolic, hyperchloremic
chloremic
metabolic.
metabolic
That
acidosis.
will not alter your treatment. That will not produce any clinical problem in the patient, but it can mislead you in the acidotic part. That's all. Okay. So you give fluid. Here you have to give little higher level of fluids because this patient is already having sepsis, septic shock. Okay.
And we've started with the fluid resuscitation, and then we've given insulin. We started the patient on insulin infusion. Potassium
So when
patients
will you start insulin? These are the problems we are going to face when we are practicing DKA. It is not immediately you should not start insulin. When will you start insulin?
After potassium levels.
What all things you have to see. Potassium is one. Other one is sugar. How much drop is expected or advisable in a diabetic ketoacidosis patient after starting fluid?
100 to
100.
75 to
So
75.
that's all. You no need to reduce it faster than like 100 or 75. So sometimes what will happen if you start with fluids and insulin, the sugar drop will be drastic. Okay, that can create some problem in the patient. So you start fluid, after 1 hour you check the sugar. If it is dropping naturally, then you can wait and correct the potassium. Then only you need to start insulin. Insulin is not an emergency treatment in DK. So most of the doctors think that it is the first line treatment. It is the third line treatment, not first line. But it has to be given on the same day. That's all. So how much drop was there after 1 hour?
after 1 hour from 600, it was 525, sir.
Okay, so it's a natural drop. Like when you are diluting your blood, high blood sugar blood with water, it will drop. Okay, so that has happened. Now you can start insulin. How much insulin? What is the potassium level in this?
4.9, sir.
Should we wait for potassium correction? It is not required.
No, in this patient, we can monitor the potassium.
So you start insulin. How much insulin started?
0.1 unit per kg.
Okay, how much you have started?
We've given a bolus and then we've started the insulin.
Okay, so 6 units bolus and 6 units
Units
infusion.
infusion. And then the initial lab investigation, sodium was 131. And according to CAD's formula, corrected sodium was 139.
Okay.
And serum osmolality is 360 and HbA1c is 13.7.
Okay, so uncontrolled sugar for many days. And see, tell me something about HbA1c.
HbA1c, it's an average of sugars for the past 3 months.
3 months. And it is the average of like 50% of the last, 50% of the value belongs to the last 1 month. That is very important. So at least for last month, his blood sugars are not at all being controlled. That is very important. Okay.
And he was since the we've taken a cardio consultation and we've done a screening echo, sir.
Okay.
Screening echo was showing a good LV EF of 55%.
Okay.
And they have advised to start on amiodarone infusion as the cause for the hemodynamic instability is suspected to be the sepsis.
Okay.
Septic shock rather than the AF causing the septic shock.
Okay.
So the patient was started on amiodarone infusion with 150 milligram stat over 10 minutes was given, and then he was started on 1 mg per minute infusion for 6 hours, and then 0.5 mg per minute for the next 18 hours.
What are the advantages of amiodarone comparing with the beta blocker?
It has both rate control and rhythm control.
Okay. So now you classify arrhythmias, tachyarrhythmias into various groups. Tachyarrhythmia, tachycardia or tachyarrhythmia.
And it can be either narrow QRS.
First it is normal sinus tachycardia or arrhythmias. In arrhythmias it is again classified into narrow complex and wide complex. Narrow complex you are already told.
Yes.
It can be regular or irregular. Wide complex?
In wide complex also it is either regular or irregular, sir.
Okay.
In
Regular means what? What are the reasons for regular? Regular wide complex tachycardias. What are the reasons? It can be SVT with aberrancy or VT. Okay, SVT with aberrancy and VT. How do you differentiate in simple looking at the ECG? SVT with aberrancy, VT. How do you differentiate? Huh? Capture beats, fusion beats, all you can see. But what is the most important pattern you see in that? It is called as Brugada criterion. Direction is very important. If all the complexes V1 to V6, 1, 2, 3, everything is positive means or positive or negative. That is concordance. Okay, only one side. Then it is mostly in favor of
SV.
It is VT. If everything is positive, all complexes are positive, then it is VT. If all complexes are negative, then also it is VT. SVT with aberrancy will look like a normal pattern. V1 it will be negative, V5 it will be positive, but you can see some patterns. Okay, that's all. Or either RBB or LBB. So that is very important. When you are seeing a wide complex tachycardia, there are two important differentiation. One is SVT with aberrancy, other one is VT. In SVT with aberrancy, what are the classical three scenarios?
LBBB, RBBB and WPW.
WPW. How do you differentiate all these things?
LBBB, V1, V2 is...
It's all patterns will be similar. RBBB means rabbit tail right side will be predominant. LB means V5, V6, M pattern or W pattern will be there. WPW syndrome. Delta waves can be there, but it will be only when there is a bradycardia. But WPW syndrome, for a normal doctor, it will be difficult to understand. Okay, from the simple ECG. It has to go to a bradycardia or something like that. You can visibly see that delta wave. And what are the other features of WPW syndrome? Wide complex delta wave and short PR interval, ST depression, T wave inversion. All these things will be there when there is a bradycardia. But it is very difficult for a normal doctor to identify all these rhythms. Okay, if you don't know anything, what will you start? Amiodarone. That is the advantage of amiodarone. If you don't know all these things, you don't know about narrow complex tachycardia, wide complex tachycardia, SVT with aberrancy, then the safest drug will be amiodarone infusion. Okay, so here we have started amiodarone infusion. It has got two functions. One, it control the rate. It can control the rhythm also. Advantages other than that, comparing with beta blocker or DKA.
Less chances of causing hypotension.
Hypotension chances are less. Okay. Adverse effects?
Hyperthyroidism, hypothyroidism.
Okay. Can produce sometimes acute hyperthyroidism because of the thyroid inflammation. Later, on continuation, it can produce hypothyroidism. Otherwise, there is no major side effects, so you can safely start amiodarone in most of the conditions, like this patient is having sepsis-induced hypotension, shock, all these things. Okay.
And then the patient was started on meropenem and clindamycin.
Okay, what is the role of meropenem and clindamycin in this patient?
In patient is having a skin infection.
Okay.
So we're giving additional anaerobic coverage as
Suppose you have an acute cellulitis. What are the organisms can present like this? Acute cellulitis. It is predominantly gram-positive, Streptococcus or Staphylococcus. When it becomes chronic, like a patient who is repeatedly coming to hospital, admitted elsewhere, chronic cellulitis, then what is a change in flora?
Gram negative.
It can be gram negative or anaerobes. Both can be added to the same scenario. So gram positive will be always there because it is skin. Then gram negative can add because he has come through multiple hospital admissions. Then anaerobes also can be there. Now, why you added meropenem?
Meropenem,
What is the coverage of meropenem?
both gram negative and also as
It produces gram negative and gram positive coverage. What it is not covering? Which organism it is not covering?
MRSA,
So MRSA is not covered by meropenem. So better to add
Clinda.
clindamycin will not cover.
Teicoplanin.
Linezolid or linezolid will be a
Teicoplanin.
better drug because it's skin. Okay, linezolid or teicoplanin has to be added. Why you started clindamycin?
Actually, sir, rather than the cellulitis, like gangrene was suspected of the
Okay.
foot. He has a
So what is that syndrome called as? Why we start clindamycin to prevent some syndrome?
putrefaction.
Toxic shock syndrome.
Toxic shock.
Okay. This is one condition you are suspecting toxic shock syndrome. This patient may have, that is mainly by gram positive organism. They produces some toxins and that toxins produces shock. Okay. So to prevent that toxin production, we are adding clindamycin. Okay. So ideal drug in this patient will be like you have started meropenem, that's a wide coverage antibiotic. Then linezolid or teicoplanin like you told. Then third one will be clindamycin to prevent the shock syndrome. Okay. So these three drugs has to be given to the patient. Okay.
And patients initially, in view of the AF, cardiac enzymes were also sent for further evaluation.
Okay.
In this patient, cardiac enzymes, CKMB was first set was 8, the second set was 25, and the third set was 70.
Okay. So what do you think that it's acute coronary syndrome?
In this patient, there are other confounding factors like sepsis and AKA.
Sepsis may be the reason for this.
Yes.
AKA also can increase the cardiac enzymes. Okay.
So we are attributing that.
Okay.
But
basically, you'll have some structural like problem in the blood vessel. Okay. This might have aggravated the problem.
And since the patient is an AF, we started on heparin IV, 5000 subcut TID.
Okay. Before starting heparin, what all blood investigation you have to do?
APTT.
PTNR and APTT both you have to check. If both are normal, then you can start. Otherwise, it will be dangerous sometimes. Okay, this patient can go to DIC. In that condition, it will be helpful. Okay, otherwise, sometimes it can produce dangerous like turn back. Okay.
And since the gangrene is suspected in the foot, there is no pulses in the absent peripheral pulses were there. And there was a plan for source control since in view of significant elevation in inflammatory markers and patient is in septic shock and the foci is the foot.
Okay.
So he was planned for source control with amputation once the patient is slightly stabilized.
Okay.
So, and
is source control to be done initially or later? So if you are thinking about amputation in that type of limbs, it has to be done initially itself. Otherwise, the source will be permanent, like it may not be removed. Antibiotic cannot penetrate to an area where there is pus. Okay, it is not possible because blood supply is less, pus is there, so it will be difficult. Okay, sometimes infections can spread upwards.
In this patient, he got admitted in the night. Night, and we've taken him up for amputation by morning. So once the sugars were slightly stabilized.
Okay.
And the next day morning, they've taken him for an amputation and they've done a above knee amputation for him.
So only thing is, when you are thinking about source control is you are controlling the source. You cannot control the source here by antibiotic or whatever it is. You have to go for amputation. That will be because it's a chronic foot ulcer. Foot might have completely gangrenous. Okay.
And once the amputation is done, he's currently in the MICU being monitored. His inflammatory markers are downtrending from 320. The CRP has come down to 180.
Okay.
And the WBC count from 17,000 have come down to 10,000.
Okay. Can you use ESR instead of CRP?
ESR initially to prognosticate.
That it is CRP and ESR main difference is one is used in acute inflammation, other one is chronic.
Chronic inflammation.
So ESR may not come down so fast. It elevates also very delayed, but CRP elevates very fast and reduces very fast. So that's why it is useful in your acute inflammation. Any other acute markers are there other than this?
Procalcitonin.
Procalcitonin is infectious marker. What is the procalcitonin here?
In this patient, it was 7.9.
Okay, it is slightly elevated. Okay, then.
And ferritin.
Ferritin. What is the ferritin is done here?
In this patient, ferritin was not.
Not done. What is the advantage of ferritin, doing ferritin in this type of cases? Is there any advantage or?
To
inflammatory
burden.
It's an inflammatory marker. Huh?
To estimate the inflammatory burden.
What is the condition? If it is very high, 30,000, 40,000. HL, macrophage activation syndrome. Okay, so you can make a probable diagnosis of macrophage activation syndrome if ferritin is so high, like 20,000, 30,000, like that. Okay, so this type of case you can do it, but we cannot offer much treatment other than amputation in this type of patients. Okay, anything else?
This patient, suspicion of rhabdomyolysis was also there, as his total CK was elevated around 5,000.
Okay.
And also his
that is because of the muscle. That muscle is destroyed. That muscle is releasing. Rhabdomyolysis is a general condition, and it may be like in this type of cases, it may be very high, 20,000, 30,000. This is only because of that area there is definite rhabdomyolysis going on. Muscles are completely destroyed. Okay. Even if there is rhabdomyolysis, what is the treatment?
Hydration.
It is only hydration and give some Lasix or good urine output is the main treatment. Okay.
That's it. Currently, he is undergoing monitoring and monitoring the inflammatory markers and.
Okay. Insulin, how much you are giving now?
Currently, we've stopped the insulin infusion.
Okay. When will you stop the insulin infusion?
Once the sugars reach target insulin level around 140 to 180 in the ICU.
With acidosis
resolved and ketone is negative.
Ketone negative. Ketone negative is the end point. Acidosis the cap has to come down. Ketones has to be negative. How do you stop the insulin infusion?
We give a bolus of long-acting insulin.
Is it long-acting insulin or short-acting? Long-acting insulins are not at all good in ICU. Why it is like that? They are okay. You can give, but not very good.
Hypoglycemia due to.
So if we cannot, suppose you give a long-acting insulin, it acts for minimum 12 hours. Once you give, you cannot control it. But whereas if we are giving a short-acting insulin, maximum action will be 6 hours. That's why we give short-acting insulin bolus before stopping the insulin infusion. Then once you give one or 2 days of short-acting insulin repeated boluses, you can switch to long-acting insulin. Okay. In renal failure, what will happen to the short-acting insulin?
It will get stored.
It will become long-acting. And long-acting will become ultra long-acting. So better to avoid insulin, long-acting insulin in your ICUs. Once the patient is stabilized, you can switch to long-acting insulins. Okay. Patient is stable now?
Yes, sir.
Amiodarone, you are continuing?
Amiodarone, we after 24 hours, we change to oral dose.
How do you change to oral dose?
We can change to, after 24 hours, we can stop it and we can give a dose of 100 to 500 mg per day.
100, okay.
Between that.
Normally, we give 100 to 200 milligram TID, then slowly reduce the dose. That is a usual pattern. Okay, rhythm has come back to normal? Or?
Yes, patient is in sinus rhythm. And, rate is around 110 to 1.
What are the reasons for atrial fibrillation?
Either cardiac causes or non-cardiogenic causes.
Okay, cardiac causes?
Cardiac causes valvular diseases and congestive cardiac failure and non
hypertension,
heart
cardiomyopathies, valvular heart disease. Valvular heart disease, which is very common? Mitral stenosis. Mitral stenosis is the most common. Okay, non-heart disease, other than heart disease.
COPD and
COPD normal. This one is multifocal atrial tachycardia, but here also you can get COPD.
And alcohol and thyroid,
hyperthyroidism.
hyperthyroidism.
Okay, Lone atrial fibrillation means
Lone AF with no cause.
no cause.
No idea.
Okay. So atrial fibrillation is one of the major reason for stroke. Okay. So here it is completely reversed back to normal. Okay. How long you have to continue this treatment?
Sir, we have to slowly taper it.
Okay.
And
He had past history of
no,
this
sir.
one.
This is a new onset AF.
There is no thyroid, hyperthyroidism.
No, sir. No
Nothing
hyperthyroid.
is there. What are the cardiac findings of atrial fibrillation? Since you are a medicine BG, I am asking. How do you?
Variable intensity of heart sounds
First heart sound will be varying intensity. Then
and absence of A wave in the JVP.
absence of A wave in the JVP.
Uh,
In mitral stenosis with atrial fibrillation, what are the changes you can see?
Left atrial dilatation.
No, that is okay. Left atrial dilatation is okay. I am asking auscultatory
ejection
findings.
systolic. Mid-diastolic murmur. Mid-diastolic murmur.
Mitral stenosis with atrial fibrillation. Diastolic murmur.
Mid-diastolic.
Diastolic murmur is there in atrial fibrillation. So you have to read all these things. What will happen to the opening snap? Other opening snap will be there. What happened to first heart sound? Okay. That all will be asked in your exams. Okay. Read that.
Thank you.
Okay.